I invite Dr. Amit Verma to please come on the stage and invite all the panelists.
So I would like to invite the panelists, Dr. Vijay Patil, sir. Dr. TP Sahu, I think Sahu sir is not there. Dr. Amish Vora, sir. Okay, okay. And I would also like to invite Dr. Atul Sharma, sir. And I think, don't think Rishabh is there. Dr. Prabhat Bhargav. Dr. Gaurav Gupta, sir. And Dr. Rohit Swami. Rishabh has not come. Rishabh and Rohit are not there. So, should we go ahead with the talk?
So I think, so thank you very much, Dr. Mishra and Dr. Akhil for inviting me, and it's been a very learning discussion happening since the morning. And I've been asked to talk about a very interesting discussion on the combinatorial approaches based on NGS in advanced cancer, when to use and when not to use actually. A very interesting topic, and I know the panelists are limited, but they are experts in their field, and I have the right chairpersons to address the questions actually. So we all understand the multimodality aspects and the combinatorial aspects. And what I understand, which I was able to get the definition of the combinatorial therapy is, it involves the complementary combination of two different therapies, like combination of radio or immunotherapy or combination of drugs that can target more than one pathway of cancer formation, like combining CDK target therapies or growth factors targeting therapy drugs actually. So whenever we use the combinatorial therapies, we try to look for the approvals, the guidelines, the biomarkers, the type of mutations, the indication. Dr. Mole is joining us. Indication and histology. So there are plenty of things before we jump on the decision of whether we should the combinatorial treatment approach or not. This is what normally we do. So let us start with the practical real world scenarios. And I'm going to talk about a combinatorial approach using a BRAF inhibitor and a MEK inhibitor, Debra and Trametinib. And we all know this is an approved indication and improved combinatorial treatment. And I think all the audience can also participate if there is any need. And this is the FDA approval, which happened very recently, last year, which says that FDA grants approval for this combination for all metastatic solid tumors with BRAF 600E mutations. We know that. And this is tumor agnostic. I have just read the key lines here, even for adults and pediatric who have this mutation. And based on the ROR and NCI match study, and this was all established on more than 20 cancers. That is why it was given tumor agnostic decision. So now let me give you a scenario, and the panelists and the experts are here. This is a lung cancer case, a metastatic case with a BRAF 600E mutation, but also have a BRAF fusion and an EGFR alteration, that is the EGFR exon 19 deletion. So now I want to ask you, should we go ahead with the guidelines or should we think something else? Over to the experts. Dr. Vijay, you can take it.
So when such complicated things come, I actually take it to a molecular tumor board, and I would then pass the ball on to Pratik, and then Pratik will start asking for variant allele frequency and trying to see what pathways this would inhibit. And then we would actually, in such kind of things, I would actually, depending on the discussion with the biologist, I would take a call. I won't just say that because there's a BRAF, you give this, because there is a exon 19, you give this. Okay. Looking at all this picture, about all these factors, then we would decide on. That would be the way approach I would take.
So Dr. Amol, please.
So I agree with Dr. Vijay. See, ideally in such situation, we should have what is called as the variant allele frequency, and mere presence of a mutation did not be necessary that it is a driver mutation for that particular patient. And hence, we should have a detailed discussion with the molecular pathologist that what he thinks is a predominant mutation into this. Now here, if you see, there is a fusion of BRAF mutations and there is an exon 19. Now, for the fusion, it will be very difficult to get the allele frequency, the VAF. So if my molecular pathologist tells that for exon 19, he gives me a VAF value and it is significantly on the higher side, and because the access to the medicines for the BRAF inhibitors is a difficult situation, I will be tempted to start anti-EGFR therapy first. I will monitor the response. If the patient is responding well, I'm happy. If the patient is not responding well, then I will take a call whether to alter my treatment based upon the previous report.
Dr. Amish. So the question is, you have the BRAF V600E classical mutation. As per the guidelines, you can use DABRA and Tamatin combination. Would you use in this case, which have a BRAF fusion, a classical mutation, EGFR mutation?
So I normally pick up a phone and talk to Dr. Amit Verma about this every time, you know that. I would like to ask him, what does subclonal word mean in EGFR T790M?
So less than 5% is what we normally call as subclonal, but these are relative things, but that is meant only for EGFR T790. But the topic of discussion right now, V600E have
Exon 19 mutation
and
is there.
V600E. Yeah.
So this, combined mutations, we see quite a number of times now. And EGFR, ALK, there are WhatsApp group is posted for that. I think, the standard textbook mutation of V600E is there. BRAF mutation is there. Exon 19 deletion, we know will give us some time. So I would start with, I would like to target BRAF here. Rather than just exon 19. Yes, are there any clinical features which are suggestive of?
So it's a metastatic disease, lung cancer.
No, what I mean to say that, Indian female, centrally located, non-smoker, all these go in favor of exon 19, while BRAF is more towards the lymph nodal disease. So if the clinical features also, but if the clinical features are not contributory, I am tempted to target BRAF rather than exon, because exon 19 again is a forgiving mutation. It will give you time.
Okay. So anyway, so the message here, what I want, just please add, please. You want to add?
I will say, if it is subclonal, less than 5% of the cells are positive.
That's
and-
only for T790. But for V600E, the VAF was 13.8%, quite high. And even for the exon 19, the VAF was 25%.
So I don't
Quite
treat lung
high
cancer,
VAF.
but for melanoma, I have given BRAF inhibitors combination. It is hardly tolerable. The combination itself, the tolerance was an issue.
Yeah.
So now adding third drug would be really difficult in this scenario.
So the reason why I bought this case is that when we have a guideline, we have a biomarker, we tend to go for it, but there are exceptions. So it's a discussion is between the guidelines and the precision oncology. So I will go to our case number scenario 2. I have 9 scenarios. We have to be very quick actually.
Dr. Verma, if I may
yeah,
add one
please.
point. So this is a CFDNA report, right? This is not a tissue biopsy.
This is a
It's
block
CDX.
CDX, not liquid.
So is there any, tissue-based variant allele frequency data available for
Yeah,
this
yeah,
patient?
yeah.
For all the mutations?
All the mutations.
As well as BRAF
Yes,
fusion?
I said the 13.8 was for the BRAF V600D. For exon 19 is about 25% plus. And for the subclonal is less than 5.
And for fusion, how many reach?
So it is not mentioned in the report. Fusion, they don't mention it. But anyway, so this is the real world scenario that sometimes we tend to go for it, sometimes we do not recommend it. Sometimes we love to have clinical trials or we go with the molecular board discussion. So I think very well subscribed. So now I will make a switch.
किया क्या लेकिन?
That is not a discussion for today. So today's discussion is when to choose, when not to choose, because the debate will go in different direction actually. So we can discuss
The
that.
reason why I was asking is.
So
actually
for
we
each
need-
case, there will be a 1 hour discussion.
No, no,
actually.
because the reason is that we recently published our EGFR and ALK data, which shows that if you target both, it is easy. But as I agree with him, BRAF inhibitors, it's difficult to think. That's why I was.
Exactly. So EGFR targeting, just to give the address, once you give the EGFR based treatment, BRAF is a known mechanism of resistance, whatever you do. So choosing the BRAF as a target makes more sense, and that should have been attempted. And then that was the anyway. So I'm switching the gears right now. The same mutation, V600E this time, but the diagnosis is different. Thyroid papillary carcinoma. Will you use this combination? Yes or no?
Thyroid papillary for the first line, I won't use
No, no,
the,
not first time. It is RAI, radioactive iodine refractory.
I won't, I would stick to lenvatinib. The
And
reason being the lenvatinib, the data for response rates with lenvatinib is 65%. Any reduction in size according to select studies seen in 95%. That the data for BRAF is in the range of 40% in thyroid cancer. So that makes my choice
But-
easy.
But the guidelines still say you can use it. Will you use it at all?
So, but
Let's say if the guidelines,
I don't read guidelines. I
Okay.
read evidence. The evidence in thyroid is very clear.
okay,
Lenvatinib, irrespective of BRAF status,
all right.
has better effectiveness. So my choice will be lenvatinib.
I will contradict Dr. Vijay. If there is tumor agnostic approval for BRAF inhibitors, I have a BRAF inhibitor, maybe he's in those 35% who will not respond to lenvatinib. And so he can respond to lenvatinib too.
Dr. Amish and Amol.
So the thing is,
Amol, sequence.
No, no, I'll
Just say
just-
the sequence.
no,
more
no,
time.
no, I'll take this. The thing is, we are talking about a BRAF inhibitor in thyroid subsection of papillary. The response rate was 40%. 40. The response rate with lenvatinib in select is 65%. And this is RECIST. Any reduction in size is seen in 95% with lenvatinib. If you look at the forest plot, irrespective of the BRAF status or KRAS status, the benefit for PFS and OS for lenvatinib remains the same. Now, why would you, this in all likelihood will be a young lady in 40s or 50s, want to choose a costlier therapy, which has its limitations, has a response rate of 40% against a regimen on the basis of a phase 2 data, against a regimen who has a phase 3 data, who has a good PFS and OS data, has better response rates, and all of us have used lenvatinib much better, so we know to handle the side effects. I use 24 mg. Yeah, I use 24 mg, and we have published our results last month itself. It's the largest series from India. 25% people can only stay on 24 mg. Most of them come down, and this is known. And there's also data for lenvatinib to say that you start with 24 mg, because if you give 24 mg even for 1 or 2 weeks,
That is
is a-
sufficient.
that has its impact. And this data again comes from the SELECT study. There's an ongoing trial, randomized trial in papillary thyroid cancer, who talks about 18 mg versus 24 mg. Let's wait for the results to come. We all know that when you start lenvatinib, 80% में dose reduction होगा. But I'm not very convinced that we should be going with BRAF inhibitor.
I agree with Vijay.
So because we are not talking too much of which final drug we'll select, for the audience and for me, Amit, can you also say that is the third promoter makes any significance in this particular case?
So third promoter have no implication in the terms of response, but it is an early event in tumorigenesis. That's all for now.
And RET is normal
That is not there.
and BRAF is positive.
Yeah.
Does the lenvatinib mechanism
So,
alter?
so lenvatinib is working in an anti-EGFR, anti-VEGF fashion right now. It is not targeting any alteration. So it is a very generic approach, a multi-tyrosine kinase approach rather than a target approach. But now the question back to the experts, that if I change the diagnosis of thyroid papillary to thyroid anaplastic carcinoma, will you make a change now?
Yes,
So
I
now
would make a
that's-
change.
That is the learning here. Even if we have the tumor agnostic approach, histology, clinical evidence, or whatever has to be taken into account before you jump on the decision. That is what I wanted to bring
Yes.
actually.
In fact, and in that situation, I would actually, the challenger for BRAF then would be a regimen of, if it is anaplastic, then definitely BRAF. But if it's poorly differentiated, then the choice would be still pembrolizumab, lenvatinib. The ESMO 2022 ATLP data showed that there's a 66% response rate with around 40% having CR.
Fair enough. So I have lot many cases, limited time. I'll just quickly browse through the cases so that to have a experience. Same mutation, but different indication, colon cancer, quite commonly observed. Will you use this combination? Simple, yes and no, and we'll just take it off. Yes, Dr. Vijay.
I don't read colon cancer, but
So, okay.
I recently
But-
read about encorafenib or cetuximab data. So I
In
would
colon,
use that.
yes.
Yeah, colon, yes.
Colon, you are going to use it?
Yes.
Are you? So the guidelines, Dr. Amish, will you?
We have
use the
no other
combination?
options and this particular mutation is positive.
This
Yes.
is what, this is the real case. This is not hypothetical.
Real
This is
use.
coming from my clinic actually. So real case
So
scenarios.
Beacon trial had shown very clearly that you target BRAF and then you target anti-EGFR, you get a good response.
Yes, but that is only for the beacon when you combine three modalities, not the two combinations, that three double combination. So, but having said that, the guidelines categorically have mentioned in subheadings that it is not eligible for colon cancer. If you read it, it says dabrafenib in combination with tamibarotene is not indicated for patients with colorectal cancer because of intrinsic resistance to BRAF. Just be cautious.
The NCCN guidelines for the colon gives it, but.
But I'm just talking about the
You are
drug
talking
approval,
about double
not
drug.
tumor agnostic approval actually.
So in this particular foundation report,
Yeah.
Amit, what it tells me very crystal clear that the RAS is wild type, but you can't use anti-EGFR alone because BRAF is mutated and there will be resistance. So with encorafenib, you take care of BRAF and then you use the colon regimen, patient will respond. That is how I read this.
I agree with you. It will be
What you're
encouraged,
reading is
Combinatorial
perfectly
and
fine.
cetuximab.
I'm just trying to just correlate the guidelines or the approvals into practice. That's it. So we're not debating a molecular tumor board for each case, but the question asked by when to use, when not to use. So it is not to be used. That's all we are learning here. It's a de novo. It's a de novo. It's not on treatment, de novo. So now same case. So now we have V600K. This time it is not E, it is K, but in melanoma. Will you use this combination?
So
This is a-
response rates are less, but it does act. The
Do
combination
you
does
have the approval, yes or no?
No.
No? So I will.
Melanoma, 1 minute. So you are treating melanoma. I understand, right? So my point is that all the immunotherapy drugs since 2010, they have not segregated separately between BRAF versus immunotherapy. So I feel that tumor mutation burden is 10 mutes. You have melanoma may response to immunotherapy.
You're just focusing on BRAF for now.
My point is I'm asking a question. Will immunotherapy resistant in this case?
No, so
Sir,
patient
there
with
was a-
BRAF mutation
There was a trial
is better for
sequence.
immunotherapy, yeah. So, but the guidelines classically say that you can use this combination for V600K as well for melanoma. So again, reiterating that some things are not black and white. We have to go back and forth and see what is there and what is not. So again, a scenario. Abhi 9 scenarios. Abhi ye 5th hai. Scenario number 5.
All patients get BRAF mutation.
So
Yeah.
this is all my clinic database actually. So this is a BRAF lung cancer with fusion. Will you use simple yes or no? BRAF fusion. It's a classical driver here, but there is no other driver mutation in the lung cancer. Will you use it or not? Approval need baat kar rahe. So approval is not there, but I'm saying it is in driver mutation. Will you use it yes or no? Just say yes or no. No questions asked. No.
First line,
Okay.
first line, I won't use it.
Mhm.
If I'm against the back of the wall, I would give the
Use it. Okay.
I will give a don't know
Not
option.
so if it comes to me as a tumor board discussion, I will say yes to it. But
Yes,
there
yes.
is no direction. There is no evidence as of now. But
The
there is
problem with this is now, when you have these particular mutations positive, there are hardly one drug or 2 drugs available, and the patient has lost all other options, then better to say yes only. rather
so
than
I'm-
say no.
anyway. So let's go to the different case now. This time lung cancer with BRAF amplification. So I'm talking about different mutations, different categories. Will you use it or no? Yes or no? It is a very recent case, February 23,
So
last week.
for first line, I won't use it.
So we are talking about the.
Yeah, in any
scenarios.
line, I will actually send this patient for a pathway analysis, and if that shows it, then yes.
Oh, anyway, so the take home, I wanted to.
One minute,
Yeah,
Amit,
please.
Amit, go back. So you have to, again, see there's a large number of mutations and that's why TMB is also high. That's why TMB is also high,
Yeah.
okay? So the question here is to the tumor board molecular oncologist is that you have both RB and TP53 mutation positive. So that means that the tumor suppressor gene is not working in the body. in
This is RBM.
What is RBM?
This is a different mutation. It is only for the purpose of the condensation actually, chromatin
Okay,
condensation.
okay,
It is
okay.
not related to that
So,
RB mutation. Yeah.
Which is the driver mutation amongst all
It
this?
is NF1 and BRAF.
NF1 and BRAF.
BRAF.
Okay, so can you show some pathway of NF1
No,
BRAF?
no.
Okay.
So they are different, they are in the same lines, they are activating the same pathway, the MAP kinase pathway.
Okay, okay.
Can you please also tell us what is the copy number of BRAF?
I have nothing, no information right now. The detail is not available.
Will be very critical to.
So the message what I wanted to bring here is that all the mutations are not same, even if it looks like. The drugs can be applied, cannot be applied. A molecular tumor board discussion, very detailed information has to be there before we take a call. That's the message. So this is the classical types of BRAF class 1, that is V600E. But the fusion lies in the class 2, which is a well-known thing. Over there, the combination is not required. A single dabrafenib can work. A BRAF inhibitor works actually. And similarly for the class 3. So now a next combinatorial approach, ABCP. Everybody have used it actually. Not many, but this is approved post EGFR, gives OS benefit, and this is non-biomarker space selection actually. So this is a case, again, a real world scenario. Patient is a known EGFR mutation, received afatinib, even also chemotherapy, progressed, have classical mutation, that is MDM2 and PIK3CA. MDM2 is known for hyperprogression, PIK3CA is known for the poor response to immunotherapy. Will you use ABCP protocol in this case? Yes and no, simple. So
I would actually call up Dr. Ullas Batra and ask with the studies
Ullas
ongoing of.
Batra's case actually.
I saw that.
Ullas Batra's
So
case,
there is
yeah.
if I'm not mistaken, there's a post EGFR amplification, amivantinib and mobocertinib trials going on. I'll tell him to recruit on that study.
So, but please.
No idea.
No, we will use it because there are
You
no
will
other,
use
yeah, there are, what are the other
Hyperprogression
options?
with MDM2.
What are the other options available for me?
You can do a different second line. You
but
can
in
go for
Is it going to be, effective? Patient has already progressed, right? On
already
the
already progressed.
patient has already progressed on EGFR mutations, first line, second lines, and there are no other options. Of course, I will use it.
With
there are
MDM2,
two
MDM2, I have
contraindications
my
for chemotherapy.
reservations. You should
No,
never use it.
1 minute.
Yeah.
L858R mutation is positive. The second generation EGFR inhibitor has been used. We have a third generation EGFR also.
Try that.
So question is, will osimertinib not work in this patient?
It can work.
Simple.
Yeah, it can work. So the question is not about that. The question is the ABCP protocol is given without a
We
biomarker
have seen
approach.
together,
Yeah.
MDM2 amplification actually in 3 of our patients had a very bad hyperprogression. Very bad hyperprogression.
So 2 more scenarios to go,
Sir,
and then
but if you look at this patient treated with osimertinib in the absence of a T790M mutation, what is the chance that this patient is going to respond? And the second question also is to you with ABCP. I understand first line study tha. We are looking at a patient जिसको afatinib मिल चुका है, PEM carbo मिल चुका है. Third line में ABCP का मतलब tolerance. I'm not used much of ABCP, and that's why I'm asking. This is what is the kind of tolerance to a 4-drug regimen in a third line setting?
So let's put it that way. Patient has progressed on afatinib. Patient is progressed on PEM carbo. Patient does not have T790M mutation. So the chances that the third generation works over second generation is less. But the point is in ABCP, atezolizumab, hyperprogression of the disease on MDM2 amplification is a known thing. My point that he can answer, I have seen all 3 cases, all 3 had
Quite
hyperprogress, but these are mine are very small numbers. So we cannot.
इसमें हम docetaxel ramucirumab या docetaxel nindatinib जो hyperprogression के लिए आया था, अभी भी options है. Why are not we thinking about a chemo plus ramucirumab or a chemo plus nindatinib
So
combination?
in those things, the hyperprogression on immunotherapy alone, so hyperprogression on immunotherapy alone is something which is not being studied, that just it is because of MDM2 and other genes. You add chemotherapy, you prevent hyperprogression of some 5 to 7%. Second important thing is that ABCP may you want to add, you already have this thing, chemotherapy. You want to add one more drug?
I'm asking.
So
this, if-
ABCT you want to give.
No. My thing is, if you have ABCP, docetaxel nindatinib, docetaxel ramucirumab, why not docetaxel ramucirumab, docetaxel nindatinib in this patient?
So you have so many other
I
options. So-
also think.
So the idea here for this case is not to go for ABC protocol, even if there are suggestions actually.
See,
That's all.
My whole
That's all.
point is this, the patient has progressed on TKI, patient
Yeah.
has progressed on chemo. IO should be attempted for a 48-year-old gentleman because probably that is the only
Knowing
option
the
left.
fact the patient have MD/M2 should not be attempted. That is what we are trying to bring actually.
Is it 100% that the IO
So
will not
nothing
work
is
in
100%. There
I
is
don't
no
think so. Anything is
100%.
100%. That is exactly what my point is. That most of the times we get a report showing that something is present.
So if
But
you
that,
are,
that is not sacrosanct. It is not like trastuzumab working on anti-HER2 drugs.
Says that you can use ABCP in your patient based on the guidelines. Based on the NGS report, there is a suggestion that you try to avoid ICICI. Nobody will hold you liable if you use ABCP.
exact,
That is what the concept of molecular tumor board is.
सर एक और डाउट है मुझे इस पेशेंट में जो the second line data which came for lung cancer initially which came with single agent nivolumab or single agent pembrolizumab उसमें भी थोड़े mutation positive patients थे उसके बाद ये था so why not rather than giving ABCP which is a 4 drug regimen in the third line why are we not considering giving only pembrolizumab only nivolumab to this patient
No, ABCP mein, what he is saying, issue is with atezolizumab. One. Second thing is, please, Vijay, remember, why are we getting, say, PD-L1 80% in lung cancer or PD-L1 90% in lung cancer? Why are we getting 70% response rate? Why? Where is those 30% who don't respond?
I agree
So
with
there may be some explanation. This is not sacrosanct.
No, I'm not. So we have data from MSKCC, which came, I think, within the last 1 year about STK11, KRAS, and KEAP mutation, and which says clearly that if you have all three of them, they don't respond. I agree.
STK11 and KEAP in other subsites may respond.
So my point was like, why are we like ABCP ही देना है इसमें? Why not new?
Not ABCP.
No, wait 1 minute. ABCP trial में EGFR subset में ABCP was seen to be working. So the point is, if patient progressed on afatinib, if you don't have T790M mutation, you can use ABCP as one of the legitimate choice. You have decided to use ABCP, patient is going to spend 5 lakh rupees and you have an MDM2 amplification. Be careful, that is the only thing. There is nothing beyond that.
तो मुझे से जो ABCP नहीं देते उनको सोचना ही नहीं है.
so anyway, you are perfectly, the message here is nothing is sacrosanct.
What was actually given? Yeah, any idea what was?
Abhi, I have to rush for a flight actually. So I have 5 minutes to close and we have 2 case scenarios. The combinatorial approach using IO plus VEGF, that is pembro and lenvatinib, which is currently being used actually, irrespective of biomarker. So we have this case, a metastatic C endometrium who have failed the chemotherapies, and we did the foundation and you have the results here. You can read for Pratik actually, you have the VAF, I have just put the VAF. It is a classical P53 mutated subtype of endometrium with a KEAP1 mutation, which you were discussing right now. And this is the molecular classification of endometrial cancer. When you fit the genomic profile into classification, you will see that the patient lies in P53 abnormal copy number high type of variant, where the copy number of KRAS and cyclin E1 was quite high, more than 17, low TMB. A TP53 is normally seen, and triple P2R1A, which is a classical thing of P53 abnormal molecular subtype, was seen in this patient. So you can see triple P2R1A. So it is a classical molecular subtyping done by the DNA test. It is not done by it is just extrapolation. Now, having said that the patient have a poor prognosis on chemotherapy, a KEAP1 biomarker is a known biomarker for poor response to immunotherapy. Will you use IO plus lenvatinib? That's the question.
I would use.
You would use?
I would use.
Okay. What you would use?
I would use pembrolizumab because as a result, this is poor results with chemo also. There's no other options for this. He's already progressed with Paclitaxel.
So pembrolizumab has in the second line category 1 recommendation for endometrial cancer. So you already have. Second thing is KEAP1 here is 6.4%. It's not that. Now RAD54L, is it an immunoresistant gene?
It's HRD gene.
HRD gene, right? So then I will use.
Okay. So But what I will give you what I did actually for this case, because right now we are discussing.
Must
Please,
have added low dose of olaparib.
No, no, not at all. No, 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 no. I did
Yes,
something
based
different.
upon whatever the clinical data we have, and because of this patient has no much of the options left, better to use it, of course.
Okay, so I give the combination because of the poor performance and the poor response to prediction to the IO plus Lenva, and a low dose chemotherapy this time. And it worked actually. So within 3 cycles, patient CR, after 6 cycles, everything is all fine, and she is not on treatment anymore because of the other factors.
But with VAF of 45% for RAD 54,
So we,
is there something wrong if you say third line, for example?
you can consider PARP.
Which
Okay.
low dose chemo was given?
So again, paclitaxel.
Again, Paclitaxel was given.
Yeah.
She was carbo in spite of
So
RAD 50.
RAD 54 is a reflection for us to platinum sensitivity, so that was continued even on progression actually. But this time again combined with that. So now this is the case scenario number 8. HCC approved therapy, atezo and bev. We all know that. But the patient had STK11 alteration. Would you use this combination, approved combination? Yes or no?
Can I take first? So HCC में Atezo-Bev, there is 2022, 2023, 2021. There is a clear-cut subset analysis that if the patient is not hepatitis B and C positive, then lenvatinib is better than Atezo-Bev.
Okay, so another taker, but from the molecular point of view, as predicted, the patient was given this treatment and progressed within 3 months because of the patient STK11 mutation. Again, last case scenario, and then we have 1 minute to go ahead. This is a CA ovary, failed paclitaxel carbo, this is a very recent case, February 2003, last week actually, have PDL1, PDL2 amplification, which is corroborated with 95% PDL1 on IHC. Will you use the second line therapy, that is lipodox and Bev, plus minus ICI? So plus minus ICI is the question, will you use it or not?
How early she has failed on paclitaxel?
Less than a year.
Less than a year.
Yeah.
She's 17 and I'll see the performance status. That's a geriatric assessment.
That's a
If she is not
clinical
fit, it will be
discussion.
Best supportive care.
It's
in
a
most of the
clinical
situations.
discussion. So from the molecular discussion, we are taking everything is all perfect for you to start the treatment actually.
From the molecular, then you would-
Yeah, that is your take.
Give recommendation, then it's your
It's your choice.
With this,
So, 1 minute. So why have they written targeted therapies with potential clinical? Because of the 95% PDL1.
Well, yeah, 95%.
That's why they have said that this can be used.
So question is, would you like to add IO when the biomarkers are saying in that favor? Though in ovarian cancer, we don't have any recommendation for, yeah. So it is this right now, the earlier cases where we have the approval, but there was no molecular guidance. Over here, we have no approval, but the molecular guidance, what to do actually.
I would use.
Huh?
Low dose, Baba.
We will use, say, as a clinician, we have to look at what are the options available and what are the chances of.
I'm giving you the options. Lipodox Bev is the option. You want to add IO or not this time? That's the
I will
question.
add.
You will add?
Yeah.
Very fair enough.
This time because toxicity is less. So like if somebody can add low dose chemo, then in this case, obviously low dose chemo.
So
None of the mutations in foundation report suggest that it will be immunoresistance, right?
JAK2 amplification is there.
JAK2 amplification,
Yes.
but it is
And
amplified.
Richter amplification also.
Okay,
Both of them
okay.
are against the use of IO,
Okay,
but I would use this.
understood.
in
But they
my
are not
recommendation.
classical of
Dr.
immunoresistance.
Amit, I have a question.
Yeah.
Say that this is
Vijay,
against,
Vijay.
no, let me just,
Yeah,
because there are students here. We say that this is against IO, what is the sensitivity and specificity or negative
Yes.
predictive value of
So-
saying that, let me complete, of, and what confidence we have denying the patient a standard NCCN recommended or regimen on the basis of this report saying that, okay, this goes against, this goes not in, what is the sensitivity, specificity or negative predictive value of this biomarkers?
See, why my whole point is that that these particular reports are not exactly like matchmaking reports, that this is there, so this should not be used, this is there, it is not perfect science like targeted therapies. That HER2 is present, use trastuzumab, HER2 is absent, don't use trastuzumab.
So
This is the data for these particular small, whatever markers or genes is not yet that robust to say that if it is there, don't use. It is less likely to be useful. You can explain to the patient and do that.
So, Vijay, both you and Amol are absolutely right. And that's why we are discussing here today. If there would be a robustness of data, then simple question to answer we all will be having. Okay. One. Second thing is, you talked about the student, Vijay. NACT का we have been discussing for last 10 years. 10 साल पहले भी और अभी मैक NC 2021 में भी one line is there, induction chemotherapy was not helpful. Okay. Same students, if there are any students who are there, but they believe you because you are producing data. 1 minute. You're
Sir,
producing.
so
Let me now complete.
Let me tell you, sir.
Vijay, you have to allow me to complete now.
Let me take that point. You. बोलो 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 बोलो
Leave it.
अरे बोल लीजिए यार. No, I'll tell you.
You cannot be so forceful in life. That is the first thing which I want to say. All I think molecular tumor board, in our experience and in many other experiences, there are data after data. He will send you 2 data based on if you target in a metastatic setting, first line. If there are 7 or 8 mutations present, and if you target 4 mutations or more, the overall survival is far superior to the standard of care. Okay, there is a data to that. Nobody is telling that don't change your treatment. This is just a suggestion. Amol, if you strongly believe best supportive care is for my patient, give best supportive care. Nobody stops you from that. The idea what is there is that you have a TP50, you have a PD-L1 of 95%. Okay. Now it is not a tumor agnostic biomarker, but you have a platinum refractory CO ovary here. Forget about 79, say 59 female. Lipodox Bev is one of the option. You have justified in using Lipodox Bev, but with PD-L1 of 95%, and you have asked for foundation 1, would you counsel your patient for immunotherapy? That's the only question.
Correct. So you finished? Yes. So that is correct. I'm not against that. I am against कि हम Jack 11 देख रहे हैं ये. I am not aware of any biomarker data. In fact, Shiva trial, Lancet trial was negative. It was negative trial. I am not aware of any biomarker data unless up till this MSKCC large analysis came, which shows that ये markers है तो immunotherapy काम नहीं करेगा. I am not aware of even such data for PD-L1. We have data which is differs from site to site कि यहाँ PD-L1 काम करता है, यहाँ काम नहीं करता है. My is कि when you are against the back, 3rd line, 4th line, 5th line, it's okay. Saying in 1st line and 2nd line कि we will change therapies or we would deny patient therapies. You want to add IO? That's a different story. But you would deny a standard 1st line recommendation on the basis of this data is a bit.
You are absolutely right, Vijay. I was exactly like you in all the 3 patients when MD-M2 amplification was there. I told him, I said, this is the standard recommendation, Amit. He said, go ahead and use it. I saw hyperprogression in all 3 patients. So all point is that I don't believe 70% of what he says. That is your prerogative. This is our understanding. How you want to take home is your choice.
Anyway, so that is why we have not a single man driven tumor boards.
Okay.
A molecular
Let
tumor board
me-
with the
No,
chair.
let me ask one last point.
We have time is over actually.
Yeah, let me put one last question to everybody's here. Are these reports given by the molecular pathologist, signed by molecular pathologist?
This is the every approved reports.
No.
Yeah.
My whole point here is that from a medical legal point of view, or for a explain to the patient point of view, are these reports, I'm asking you, are these reports signed by a molecular pathologist, and our molecular pathologist can give recommendations to the clinicians that this should not be used or this will be more useful or less useful? Are they allowed to do that? That is my simple question.
So the molecular tumor board is what we are trying to address here actually. Molecular tumor board is the answer forward. It is not a single man driven recommendation. It is a consensus beyond the guidelines when you have atypical scenarios. Actually.
My whole point is that when such reports are issued, now sometimes patients read them and they feel that this is the sacrosanct truth. So I will suggest, I agree that it is written that it is suggestion, one line should be added that this should be correlated the way radiologists put na, always have clinical pathological correlation. The same way in this report should be written that they should be have a molecular tumor board discussion or a clinical
All right,
pathological correlation.
I think your point is well taken and it is a message for many other people to follow. Thank you very much, Amol, and the panelists and expert panelists.
Next topic. I think we can go for the next talk because I think my wish is that you should take lunch before going to the flight.
So Dr. Verma decided that we are ending on the very high note.